Hey, Journal Clubbers, and welcome back to this episode of the Overrun's Journal Club on Monday afternoon. Today, we're going to talk about multi-sequential defibrillation. Usually, it's seen as dual sequential defibrillation or double sequential defibrillation. And today, we're going to talk about a case from 2019 that's been reemerging on social media about a triple sequential defibrillation that ended with a good outcome. So, Danny, we've done these procedures before in the field. What are your thoughts on dual sequential defibrillation as a practice?
You know, I kind of go back and forth with it. When we first got it, I was really excited about it. I thought it was a really interesting way to change practice. It made a lot of sense. I found that logistically it was a little different. It was, 2 monitors, 4 pads,
Right.
2 people operating the machines. It was, at first they were calling it the big 720. It's not really 720. But it's 720 joules because you're not doing that. I know some places that are still doing it. I know some places that are not doing it. My shop right now does not do it. My shop before I came to where I'm at currently did it and was very aggressive with it.
Yeah.
I think that there's something. I think there's something to it. I think there's something that potentially has a benefit, but I don't know that that's been borne out in the literature. And I think it's logistically very hard to do.
Yeah, and we've discussed previously for cardiac arrests, we still have no idea what the hell we're doing. It's this is a practice that kind of came into vogue in the mid to late 2010s, and mostly it was about you're running this code. You've got this patient who you're working a refractory arrest for 30 minutes, 40 minutes, and you're just kind of throwing everything against the wall and hoping something sticks. A lot of times in patients, part of the problem with defibrillation is that their heart might be turned in their thorax a certain way. So the idea with dual sequential is that you hit a different vector of the heart to actually get some sort of impulse and to get the heart started again. And when this literature started coming out, it was kind of implied that this is a brand new procedure and we're just starting it. And, devotees of the show will know that, of course, that's not true. So we'll start with looking at a study that came out in 1986, which is a full 38 years ago. This is a canine study that came out of Indiana. Double and triple sequential shocks reduce ventricular defibrillation threshold in dogs with and without myocardial infarction. Now, what's important about this is, again, this is a canine model. This is looking at whether or not doing double and triple sequential shocks affect the heart with or without MI. So really they were looking at, does it do additional damage to the myocardium after the actual MI has occurred? This paper, again, it's a canine paper and it just kind of discusses how double and triple sequential defibrillation works, but pointing it out that this is not something that's brand new. This is something that has occurred or has existed for almost 40 years. So when you go out and people are saying, we're trying this brand new thing, nothing is new underneath the sun. This is a practice that we've tried for years.
It was like a proof of concept, right?
Right.
It was like, let's see if this works. Let's see if defibrillating with a different vector or changing the vector or giving multiple shocks across different vectors would actually stimulate the myocardium to depolarize more tissue, right, and get you a more and kind of bring that natural inherent pacemaker back and pull them out of VFib or VTAC. Because that's what we're talking about, people. It's a VFib VTAC arrest that's refractory to our initial defibrillation and our initial meds.
And this is, again, it's a skill that it's almost a last ditch effort. So you've gone through ACLS, you've exhausted, all of your epinephrine, all whatever other medications that you're using. And, it's, again, it can be very cumbersome because if you're working at a shop that has several monitors to do this, you have to send someone out to the truck to get the second monitor. There was some discussion about whether or not we can use an AED as a second monitor. So it's certainly not something that we've fully elucidated. Something that we fully understand, I guess, but it is something that does seem to work in some settings. So we'll talk about some of the modern data here. So this is coming out of Resuscitation in January of 2024. Again, the impact of dual sequential shock timing on outcomes during refractory out-of-hospital cardiac arrest. Now, what this is talking about, and this is analyzing the actual practice of dual sequential defibrillation, and it talked about the timing between defibrillation. So one of the things that you have to do in a dual sequential is you have to make sure that the pads are applied to the patient and that each provider is pushing the shock button at around the same time. And again, we talked about how cumbersome this skill can be. And part of the reason for that is studies that we see here from January. It talks about decreasing the actual DSED interval to less than 75 milliseconds was associated with a lower probability of ROS compared to less than 75 milliseconds. So the longer time between shocks is reducing the probability of ROS. So you want to aim for that less than 75 millisecond interval. However, no association was noted between DSED interval and survival to hospital discharge or neurologic outcome. So among patients in a refractory VF and you're doing a DSED of less than 75 milliseconds, it was improved with rates of VF termination and ROSC, but there was no association noted between DSED interval and survival to hospital discharge or neurologic outcome. Now, the reason that that is important is when we get into this study or this case report from 2019, we want to mention that this isn't a diaspora. Doing double and triple sequential defibrillation doesn't save everybody. It's just one of those things that we should try. And the data tends to reflect that regardless of how fast you do a double sequential defibrillation, it doesn't tend to improve outcomes, which is why a lot of places aren't doing it anymore, which is kind of where this conversation came up, where, we have these conversations like, if we can save one person, right, we've done enough. Mm-hmm. Right. So I think it's an interesting conversation where, do we use this skill or do we keep the skill in our back pocket, knowing that generally speaking, it doesn't improve outcomes, while also knowing that we might be able to help one or two people that we see?
It's questionable. And again, there has been studies, people have been bouncing this around for a very long time, predating COVID, predating even, a lot of places.
Remember before COVID? Remember that?
Yeah.
That was fun.
Remember that? I think what we're trying to do is, we want to save more lives. We want to do things better for people, and we want to see these people walk out of the hospital. Is this the way to do it? I'm not sure. I think it probably does work in certain circumstances, but again, remember, the balance of the science does not support that this will increase survival to discharge or neurologically intact survival. One other thing you need to consider before you consider doing this on scene is you need to talk to your medical director, you need to talk to your clinical people, you need to understand your monitor and what the manufacturer says, because there are manufacturers that do not certify their machines to do double sequential defibrillation. They will not honor a warranty if they find out that the machine was used for a double sequential defibrillation. Very important to understand that when you're dealing with a $30,000, $35,000 monitor that you might fraud.
Yeah, and certainly, cost and timing is a difficult thing. And like I said, if we're going to save one person, there's going to be someone who's going to say it's going to cost too much money to do that, which that's a whole other episode in itself. But there's additional considerations. Are you using one monophasic monitor and a biphasic monitor? Are you actually getting and there was some debate years ago whether it was the number of joules or if it was the vector or if it was whatever. So you have to know, again, getting back to knowing your equipment and how it works. So we'll get into this case study, and those who follow Jimmy Apple on TikTok and saw this on his channel, he did a really good breakdown of this.
Avenger, really good guy.
EMS Avenger on TikTok, his friend of the show. He's a good guy, and he went over this pretty well. But this story is essentially, this comes out of Canada, and this is a 24-year-old male who was riding with his friends in the car and said, "I feel like I'm having a heart attack," which is that's always kind of a red flag to me. The cynic in me says, "Do you know what a heart attack feels like?" But that's kind of a red flag if someone, under the age of 40 suddenly has chest pain and says that they feel like they're having a heart attack. That's maybe a red flag you should address. So what ended up happening was this guy had a 24-year-old had an arrest. It was a VF arrest. They did high quality CPR for a long time. But essentially, along with standard ACLS and with a triple sequential defibrillation, they were able to achieve ROSC after 82 minutes of downtime. We'll get into the specifics here, but essentially what happened was 16 days after this patient had this cardiac arrest and following management of his coronary artery disease at 24 years old that he didn't know that he had, this patient was discharged with no sequela. He was neurologically intact. So first thing, an 82-minute long cardiac arrest that gets discharged neurologically intact is remarkable. I'm glad that they published this case, because this is one of those things that I don't know that you would ever see again.
You might not. I mean, the odds of this are so far away. It's a lucky shot. It was an absolute lucky shot. And I'm sure there's a ton of factors and variables that came together in this specific case that contribute to this. Probably excellent CPR or early mechanical CPR. We don't know what was done. We know high quality CPR was performed, but if they did it, they did it extremely well. Number two, consider the age of this patient. This is not a patient with comorbidities. This is not a patient with a high body mass index. This is not a patient with, any other issues.
So his history was significant for substance use and a seizure disorder. Not really contributory.
What I'm talking about is diabetes, COPD. Even thyroid issues, kidney disease, things like that. All of that's going to work against you in the intensive care environment down the road. And it's that much harder to ensure a good outcome.
And something that I think is important to point out in this paper, again, CPR was done for a long time, 82 minutes on this patient. But one of the most important things in this, chain of survival, his friends called 911 because the patient said, "I'm going to have a heart attack." They pulled over. He went unresponsive and collapsed. His friends started CPR and called 911, and his friends did CPR for 13 minutes before EMS arrived.
Excellent.
So again, we don't know what we're doing in cardiac arrest, but we know that early CPR and early defibrillation tend to work. So if nothing else, kudos to these guys for doing, or to this guy's friends for doing CPR for 13 minutes. His friends should never have to buy a dinner for the rest of their friendship. Every vacation is on him now. You've got this friend be like, no, dinner's on me. You saved my life. Getting into the John Mulaney bit about all his friends at his intervention. So back to the case. So we have this VFib thing, right? He was first attempted at 200 joules. He remained in VF and had 3 shocks at 200 joules until 22 minutes, at which point ROSC was achieved, right? So they get ROSC in this patient. They move him to transport. Again, great move by EMS. We don't move cardiac arrest. They got a ROSC back in him, then they loaded him to transport. During transport, the patient reverts back to VF and remained in this rhythm until arriving at the hospital. So ACLS management, 45 minutes post-arrest. Dual sequential defibrillation at 48 minutes post-arrest. This was unsuccessful. At 51 minutes, there was a short duration of torsades. They gave him 5 grams of MAG. After ongoing ACLS at 56 minutes post-arrest, the patient received intralipid, and because they were worried that they might actually have some medications that were stuck in fatty tissue to try and get rid of that. His ventricular fibrillation persisted despite five further attempts at dual sequential defibrillation. So when we said earlier that this is a skill that you don't do often and it's a last ditch effort, this patient had almost 7 dual sequential defibrillations before they decided to move to a triple sequential. We'll get to this picture in a moment, but after 67 minutes, they gave a 30 milligram bolus of Esmolol. Esmolol is a beta blocker. It's going to reduce the fibrillatory threshold. The idea is that you reduce the fibrillatory threshold, do a defibrillation, get the patient's heart rate back.
It slows conduction through the ventricles. So the idea is for that kind of unorganized rhythm, if our conduction slowed, it might slow that irritable focus that's causing the fibrillation.
Absolutely. And so now we have 67 minutes, and now we have Esmolol on board, and then another dual sequential at 400. At this point, the team was talking about terminating the resuscitation, but they decided to attempt a triple because why not?
The old triple Lindy.
We're going for it. So he received a simultaneous He received a total simultaneous dose of 600 joules at 70 minutes post-arrest, and then went into PEA for about 10 seconds. They did more CPR, 5 minutes of CPR, back to ROSC. After 3 minutes, he reversed back to VFib. At 80 minutes after the arrest, they do another triple sequential shock, and they get ROSC after that. They do an EKG after they get a ROSC. They find an anterior ST elevation MI. It gets brought up to the angiography suite. He's got a complete LAD occlusion, which, I mean, when you hear about someone who feels bad and goes into VF arrest, it's almost always an LAD occlusion. He was stented and he went out. He had some systolic dysfunction, which is not surprising given what happened to him. And this patient walked out of the hospital 16 days later, neurologically intact. So let's talk about the skill a little bit. Here we see the placement.
An unreal, commendable effort by this resuscitation.
Incredible.
Just
a
baller play to do this. Like,
absolutely.
Not giving up on this kid, and just the things that they brought to bear outside of what we consider traditional ALS. This guy, this was a resuscitationist thinking outside the box.
And this, when you think about how many patients we have that we work for 15 or 20 minutes and, maybe we transport them, but, we get there and they're just like, all right, thanks guys. And then, they just kind of ship them off to the morgue. It's impressive to me that, and certainly in a hospital, it's a little bit easier because you have teams working with you.
Sure.
But again, the patient was worked for 40 minutes in the ambulance.
Right.
What I thought was interesting is
hospital care and in hospital ED care. Just a phenomenal job by everybody involved to actually get this done.
These guys crushed it. And part of it too is here on the screen left, you can see the resuscitation room where they have the bed, they have all the different crash carts around him so that they can do triple sequential defibrillation. And here we see the pad placement on the chest. So we have your AA, the capitals are the anterior aspects. So you've got one right around the placement where you put V1, and you've got A over here, typical pad placement. Then you've got the anterior posterior placement here, which again is something that we've talked about, might have a benefit. And there's an additional set of pads where letter C's are. So that was the setup. And again, 600 joules. And even then, after 600 joules, they still had to do that twice, right? So all of this to say that there are some tools in our arsenal that can help this patient. And again, this is a 24-year-old triple sequential defibrillation that lasted over 80 minutes and got ROSC with good neuro outcome. This paper was published in October of 2019. So when we think about the patient and we think about the time it takes to work that arrest, again, the most fascinating thing to me was the time spent actually working the patient. Right. We know that there's some sort, when you do CPR, you use epi, you shock the patient and you get some activity, like, there's something that's in there that can work.
Right.
Right. So first thing, kudos working for over an hour on this patient who ended up having a really good outcome. I think it's an interesting conversation about multi-sequential defibrillation. I think it's an interesting conversation about using Esmolol in cardiac arrest. And it's all stuff that we've discussed over the years. What's frustrating to me is that this was published in 2019 and we're talking about it in 2024.
Yeah, I mean, but that's the way inertia works in medicine, right? It's a great idea comes in and it takes 10 years or so before people start paying attention to it. I am interested in Esmolol, and I think it's got some applications. The early literature behind it seems interesting. Does it bear out to large populations? Who knows? Let's do a study. One of the quick things that we can take from this, a clinical pearl that we can take away from this is nobody has 3 monitors in their truck. I don't care who you are. Right. What you can do though, if you have that refractory VFib, and maybe you're a shop that has a monitor that you can't do it on, or maybe you have a monitor that or your place doesn't allow it. What is acceptable? And obviously run it by your clinical people and run it by the medical director. Try a vector change. If you've shocked them 2 or 3 times and you're not getting any kind of conversion, you can take another set of pads, place them on a different vector, whether anterior or posterior. You can move them more lateral, but change the vector and shock through those pads and see how it works. A little bit more logistically, yes, you're going to use another set of pads, but you might get a good result. It might depolarize just a little bit more of the tissue that you need to kind of terminate that rhythm. That's what I would take from this as a practice guidance or something to kind of think of in your back pocket. When you're out on the scene, you have that refractory VFib, you do have that conga line of good CPR, or you have early mechanical CPR, which is not inferior to manual, and in a lot of ways logistically much better to deal with when you just have a Lucas to deal with. You can actually shock through the compressions. You don't have to have pauses. You can change vectors on the fly with a single monitor. and another pair of pads. Most places will carry multiple sets of pads. This is something we can take with us and maybe use down the road. Unfortunately, the early work in this was done back with those canine studies in 1986, 2019, pre-COVID. And I don't know that we're going to see large randomized controlled trials on multi-sequential defibrillation, but vector change could be a game changer.
I think recruitment for double sequential defibrillation is going to take a long time to get like a good study on it. I also think it's going to be really difficult to establish like standard treatment or a placebo against it without saying that we're withholding care.
I don't know if IRB would even go for it.
Right, which again is another roadblock where, it's going to take 100 case studies of triple sequential defibrillation for people to even start thinking about it. So
but changing vector might make a difference, and it might be something that works better for you.
Right. And understand that most things that are written are based upon treatment of a 70 kilogram white male. And almost nobody in the United States is that anymore. So, there's going to be physiologic differences and anatomical differences in all patients that you see. So, when we talk about you've seen one system, I think there's an argument to be made. If you've seen one patient, you've seen one patient. And that said, I'm very pro vector change. But a conversation I'd like to start hearing is, what about AEDs, right? Because if the argument is that this is a questionably effective tool, right, in patients with refractory VF, if we know that they're already in VF, an AED is going to see that it's in VF, right? So if you're a shop that only has one monitor, and again, this is all anecdote, I have no idea, but I'm wondering how effective it might be if they already have an AED on the patient. You go in and you take your monitor and you put like pads in the AP placement. And then this way you have two sets of pads, right? So now the timing is going to be difficult, right? We saw that January paper where you have to have less than 75 milliseconds. And that is literally the blink of an eye.
I think it's going to be more of a logistical problem, man. And I think, again, it's a manufacturer problem. Is your manufacturer going to warranty your machine? Again,
and that's a whole other operations nightmare too.
And it is, but you have to consider it. You can't take you can't take, especially with a small rural program that may only have 3 or 4 monitors or AEDs, and you fry one, you could potentially hurt people because that machine is not available.
And I think that this is something that is still kind of in the discussion. A lot of times things like this feel almost like, like early goal directed therapy, where like we started doing it, we were gung ho about it. And then it's like, it feels like it's hard to do. I don't want to do that a lot.
Remember, the thing about that was just like some of the things that we found out with going back to the bad old days of COVID, we thought that the data was telling us one thing and it really wasn't. Like, flooding people with fluid originally sounded great in sepsis because they need fluid. They didn't need as much as they got, and we started seeing more problems down the line. So, I consider sepsis one of the first FOAMed illnesses, because it was one of the first ones that was really talked about in FOAMed, and people were pushing things like early goal directed therapy and putting in Swan-Ganz catheters and invasive cardiac monitoring, invasive pressure monitoring, and looking at central venous pressure. And then we found out it doesn't do it.
Right. And that's what I think. I think that these skills are interesting to think of. And when I think of the patients that you get, like how many refractory VF arrests have you had? They're not super common.
Right.
So, but I do think it's an interesting conversation when you do have those patients. And if you don't have Esmolol, have a conversation with your medical director about what beta blocker you have, right? Do you have labetalol? Do you have metoprolol? Whatever you're using, because they're all somewhat similarly effective and they all reduce the fibrillation threshold. But we're interested in what you guys have to think about this. Have you seen this study? Have you done it in the field? Be sure to like and subscribe down below and check out the articles that are down in the show notes. And this is this week's Monday afternoon journal club. We're going to start calling it magic, I think. Magic. Every Monday magic for here Monday on the Overrun.
All right, I love it.
Exactly. We hope you guys learned something. Thanks for watching, and we'll see you next week.
Take care. Be careful.